forest plot, right, left, diamond, line, confidence interval, touching, no effect.
Yeah. So we are in a learning phase. So should we go to next session? Okay, so we have next session by me and Prajwal. So Prajwal will go first A and B section, and I'll touch C and D. So Prajwal, you can go ahead.
Guys, can you see my slides?
Yeah.
Yeah.
Yes.
So hello everyone. Welcome to the Journal Club. Me and Dr. Sundar will be presenting on the topic early computed tomography, coronary angiography in the patient with suspected acute coronary syndrome. It's a randomized controlled trial by Gray et al. So it was published in BMJ in the year 2021. So let me start. So today, we'll be using the critical appraisal skill program tool. So this is the first page of the critical appraisal tool. So I'll be presenting section A and section B, which consists of six questions, and Dr. Sundar will be presenting the section C.
Prajwal, your slide is not moving. It is just saying Journal Club. First slide.
How about now? Is it moving?
No.
Let me. We're having a lot of technical issues today. Can you see my slide?
Yeah.
Is
So
it moving now?
no.
You can turn on the slideshow, Prajwal.
Yeah, I think the slideshow is not on. Look at the slideshow on the far right hand side bottom corner.
How about now?
So can you move the slide?
I'm moving the slide.
Okay.
Try closing the PowerPoint and opening it again.
Let me do that. Can you see my slide? I mean screen?
Yeah.
Yeah. Let me turn it on. Is it moving now?
Yeah, it's moving.
Right. Thank you for that, Ashish. Yeah. So also I was in this slide earlier. So the topic for today is early computed tomography, coronary angiography in patient with suspected acute coronary syndrome. It's a randomized control trial by Gray et al. So it was published in BMJ in the year 2021 on the month of August. So today we'll be using this tool, critical appraisal skill program tool. So basically the tool is divided into three sections, section A, section B, and section C. So I'll be doing the first two sections, section A and section B, and Sundar will be doing the section C. So let me proceed. So the first question is, did the study address a clearly focused research question? So in this question, we have to consider the following things, such as if the research question focused in terms of population studied, intervention given, comparator chosen, outcomes measured. So let's discuss that. So basically the first one, population studied, it was the one highlighted in the green. So adults with a suspected or provisional diagnosis of acute coronary syndrome and had one or more previous coronary heart disease, raised levels of cardiac troponin or abnormal ECG. So for the intervention given, it was very simple. It was early CT coronary angiography and standard of care, and it was compared with the standard of care only. So the basically patients were divided into two groups, which were like randomized. So we'll be discussing about that in further slides. So comparator chosen. Honestly, like I was not able to find like about the comparator chosen. So maybe Sarah can have a light on this later. And
So you've already actually outlined it. So the
okay.
intervention is early CT coronary angiography and standard of care, and the comparator is just standard of care. That's it. You got it.
All right. Yeah. Thank you so much for that, Sarah. Yeah. So for the outcomes measure, as you can see, which is highlighted in the yellow highlighter. So the main outcome measure. So primary endpoint was all cause death or subsequent type 1 or 4B myocardial infarction at 1 year. So it was measured in 1 year. So that's the outcome measure. So did the study, going back to the question again, so did the study address a clearly focused research question? I would go with the yes to this question. So let's move on to the second question. The second question is, was the assignment of the participant to intervention randomized? So for this, like we have to consider how was the randomization carried out, and was the method appropriate, and was the randomization sufficient to eliminate systemic bias, and was the allocation sequence concealed from the investigator and participant? Firstly, let's discuss about the method used. So the researcher performed a prospective randomized open-blinded endpoint parallel group clinical effectiveness trial. So it was done across 37 hospitals across the UK. And so going back to how was the randomization carried out, and was the method appropriate? If you go to page number 2 under the method section, you can find out under the participants and randomization. So adults with the symptoms of suspected acute coronary syndrome, or those with the provisional diagnosis of acute coronary syndrome, and one or more of previous coronary heart disease and raised levels of cardiac troponin or abnormal echocardiogram ECG were recruited in this study. So either they were recruited in the emergency department or during the hospital admission. So they have also mentioned that table S1 lists the full eligibility criteria. So however, I was not able to find the table in the paper we were given. So before the participants were recruited in the study, informed consent was gained, and the participants were recruited for the trial. And they were grouped by a site and with the variable block sizes. Going back to the question, how was the randomization carried out? Was the method appropriate? I think it's a yes. So was the randomization sufficient to eliminate the systemic bias? I think it was. It's also a yes. So was the allocation sequence concealed from the investigator and the participant? So for this, I would go with a no, because it's a open-blinded trial. So both the participant and the investigator were known about the what treatment they were getting. So
yeah, I think you're right. There is another point later on, which I think one of the questions will bring up. The method of randomization, you had highlighted it on your little slide. It was they used a web-based randomization software to make the allocation.
Thank you, Sarah, for that. Yeah,
that's it in green at the bottom of that other one.
All right. So moving forward for the question number 3. So the question is were all the participants who entered the study accounted for at its conclusion? So we have to consider whether the losses to the follow-up and exclusion after randomization accounted for. So were participants analyzed in the study groups to which they were randomized, and was the study stopped early? If so, what was the reason? So for we have to go to this flow chart. So as you can see in this flow chart, there were total 16,193 were assessed for the eligibility. So out of that, 4,444 excluded because of they were not ineligible, and total of 1,749 participants were randomized. So during the a study, one patient withdrew from the study. So two groups were allocated with 877. The first group is allocated to CTCA and standard of care, and the second group was allocated to standard of care only. They were like 871. So in the first group, follow-up ended up prematurely. So there were a total of 2 participants. And in the second group, which is for the standard care only, there were 3 follow-up ended up prematurely. But however, they were all included in the analysis of primary outcome in the both group. So as you can go to the first section of the question number 3. So there were people who were lost to follow up were included in the final data analysis. So going to the second question, were participant analyzed in the study group to which they were randomized? I would go with a yes. And was the study stopped early? If so, what was the reason? So no to this one. So overall, were all the participants who entered the study accounted for his conclusion? So I would say yes.
Yeah, I would agree. They did make the point, although there are very, very few dropouts, they took the date of the last contact as the finish date, and they took data up to that point for those that had pulled out after they'd received treatment, but they couldn't follow up. So I think they're right to say that they carried out an intention to treat analysis. I think if lots more people had dropped out, it would have given them a problem. But because it's 2 and 3, I think they were able to carry out the full analysis on everyone that they started with and assume some data at the point at which they left the trial for the rest.
Yeah, thank you so much for that. So going back to the questions, so let me talk about section B. Was the study methodologically sound? So let's go to question number 4. So the first thing in the question number 4 is, were the participants blind to the intervention they were given? So I would say no. Participants knew, they were divided into 2 groups. So they knew if they were getting the CT or CT plus standard care or just the standard. So they were not blind. And were the investigator blind to the intervention they were given to the participant? So I would say no as well. Investigators knew what treatment to be given to the patient, and the people assessing, analyzing the outcome blinded. So at the end, yes, the people who were assessing the final primary outcome were blind. So as you can go to the page 2 outcome. So in the first paragraph, it has written that an independent clinical endpoint committee blinded to the trial intervention adjudicated the trial primary outcome. So the people assessing, analyzing outcomes were blinded. The study methodically sound. I would say I can't tell because the participant and the investigator were not blinded, but analyzer were blinded. What do you have to say about this, Sarah?
No, that was a really good summary. I agree.
So going forward to the question 5, were the study groups similar at the start of randomized control trial? So we have to consider where the baseline characteristics study group, age, sex, socioeconomic group clearly set out, and were there any differences between the study group that could affect the outcomes? So I would say yes. They were clearly set early in the research. So if you can go to page 5, we have a baseline patient characteristics. They have clearly given the age, male, sex, and also they have given the cardiovascular risk factors and medical history. So baseline has been clearly set up in this study. So let me go forward to the question number 6. So apart from the experimental intervention, did each study group receive the same level of care? That is where they treated equally. So for this one, we have to consider, was there a clearly defined study protocol? If any additional intervention were given, example tests or treatments, were they similar between the study groups? where the follow-up intervals of the same for each study group. So for the first one, was there a clearly defined study protocol? So like I was not able to find any defined study protocol, so I would say a no for this one. So if any, for the second one, if any additional intervention were given, example tests or treatment. So in this study, like apart from the standard of care and C2 angiogram, like other treatments were not given, and it's not mentioned in the paper. And going to forward to the third one, where the follow-up intervals the same for each study group. As if you go to page 1 abstract, like at the main outcome measure, like it has mentioned that the follow-up was at 1 year. So there was a equal follow-up for both the group. So that brings into my part of the presentation. So if you have any inputs, Sarah, can you give it, if that's okay?
I will do, thank you. You've covered loads of really good points. I'd be interested to know what you made of table 1, the baseline characteristics. It looks, well, no, I do want to know, what do you reckon? Did that happen randomly?
Can you repeat that again, Sarah? Yeah, this one, right?
Yeah, this baseline table. If you look at the percentages they managed to get into each arm of the trial, the percentages in brackets.
Yeah.
What's your first impression of that? Do you think, yeah, that could have happened randomly, or that looks like a work of art?
Yeah, based on what they have they put it randomly, so should be randomly. I suppose.
Should be random, shouldn't it?
Yeah.
But you look at them, they're perfect. They're like
Yeah.
mirror images of each other. That is astonishing.
Yeah.
Never seen one that close. So what they did do, and they said that in the randomization process, they stratified by site, because they, as you've said, they took in from 37 different locations. So they little medal. They tell you they had a little medal by saying they'd stratified.
Yeah.
I do not believe for a second that this perfect symmetry arrived by chance, but I'm a cynic. But it's worth looking at and thinking, yeah, they really are very similar groups.
Yeah.
I've said that that's
I agree
true.
with that, yeah.
But I'm just a tiny bit suspicious that they didn't stratify a little bit further. The only other thing I was going to say was that the standard of care, forgive me if you did say this and I missed it, that the standard of care was at the discretion of the attending clinician. So the possibility to introduce difference there is quite high. If they said they were following guidelines, but there is the possibility that standard of care itself varied quite considerably across sites and between clinicians.
Okay.
But no, thank you very much. You've hit so many good points there. I just wanted to point out the baseline characteristics because it's worth a little look and think, is that too good to be true?
Yeah, it looks so perfect in the board group. Yeah, I agree with that. Yeah.
No, thank you. That's all I had.
All right. Yeah. Sundar, would you like to continue if that's okay?
Yeah. So can you in the slide share? So I will share my slide. So is it visible?
Yeah.
Okay. So regarding this paper, so basically they have done well job, every question is asked, but the final result will be different one. So thank you, Prajwal, for doing the section A and D. So I'll do on section C, what are the results, section D, will the result help locally, and finally the appraisal summary. So in the section C, what are the results? So we'll look in question 7, 8, and 9. So in question 7, where the effect of intervention reported comprehensively. So as no or can tell, so we have to consider
Sundar, I want to interrupt you. Your slide is not moving as well. So
okay, so let me do the same thing here. So
I'll close your presentation and then do the sharing again. it worked for me that way.
Okay. Mhm. I'm opening my slide. So, okay. So is it visible?
Yep.
It's visible, but
Is
can
it,
you move your
is
slides?
it moving?
No, it's not moving.
Is it not moving? Okay.
Just close your presentation first. This one, like close it, yeah.
So
Now share your screen and then open the presentation. First share your screen.
is it visible by my desktop?
Not yet.
Not yet. So let me share my screen. Is it visible?
Yeah.
Yeah.
So I have lots of stuff. So is it visible now?
Yeah.
And let me, is it moving?
Yeah, it's moving now. Yeah.
Okay.
Perfect.
We're there.
Yeah.
That's a good tip. I'm going to remember that one.
Yeah, so basically I'm discussing regarding section C, what are the results? So basically in question 7, where the effect of intervention reported comprehensively. So to consider this question as no or can tell, we have to consider different like questions. So first is the was a power calculation undertaken. So basically like a power calculation is made before the study to calculate the sample size necessary to detect the difference between the outcome in the control and intervention group. So this will be based on the like previous similar studies or pilot studies. So basically they put power calculation around 80 to 90% of standard, but in this like group, the researcher, they don't manage to recruit enough people. Sometimes they the study is underpowered, or they have recalculated the power calculation. So are you prepared with your paper? So I'll signpost like it is in the page number 2, study power and sample size. If you go to the paper, then it will have like study powered sample size. So initially resources calculate around like 90% of power and a two-sided p-value of less than 0.05. So total the evaluated patient will be 2,424 patient. But later on they have like given like the lower than anticipated 12-month event rate and the much slower rate of recruitment. So they have reduced the power, like they consulted with the trial funder and trial steering committee, and they recalculated the sample size. So they have decreased the power to 80% and calculated the participant of 1,735. So what the power calculation undertaken? So the answer is yes. So next is the what outcome were measured and where they clearly specified. So if you go to page number 2 in outcome section, so you will get like they have divided in the like primary outcome and the key secondary outcome. So if you go to the like primary outcome, so basically the primary outcome will be all cause of death or non-fatal myocardial infarction. In the key secondary outcome, it will be like a death from the coronary heart disease or non-fatal myocardial infarction, death from the cardiovascular disease or non-fatal myocardial infarction, non-fatal myocardial infarction, death from the coronary heart disease, death from the cardiovascular disease, or death of other causes. So basically they divided into the two sections of outcome, like primary outcome and the key secondary outcome. So the answer is yes. So how were the result expressed for like binary outcome, where relative and absolute effect reported? So if you go to page number 7, like primary and the key secondary outcome table 3, then the table 3 will like they have divided primary outcome, secondary outcome, and they have put like in the computed angiography or the standard care, and they have divided into like they have divided into confidence interval and some p-value. So they have a divided two section, they have divided in the primary outcome. So answer will be S. So next is the where the result sorry, it is repeated, sorry. So where the result reported to each outcome in each study group at each follow-up interval. So if you goes to page number 6, figure 2, so you will get this one. So here like the blue line is for like coronary angiogram with a standard care, and the yellow dotted line is for like standard of care only. So they have follow up within like 0, 3, 6, 9 and 12 month, and they have put like cumulative incidents according to that. So the answer will be yes. And next is the was there any missing or incomplete data? So if you go to page 3, table 1, then you will get like this baseline patient characteristics. So in the last point, they have written like the missing data. If you see like presenting complaint, so they have one participant in the CT coronary angiography and standard of care arm. And next is on like one participant in the standard of care, only one arm. So they have like missing data in presenting complaint and the family history, in the myocardial infarction, in the medical history, previous PCI history in medical history, and previous CABG surgery. So these are the missing data they have included. So the answer will be yes. Next is the was there differential dropout between the study group that could affect the result. So if you go to page number 4, figure 1, then you will get this larger data. So basically they have recruited a lot of patients, like 16,193, but they have randomized 1,749. So they have like the follow-up for like 2 in the CT coronary angiography. So one withdraw consent to further follow-up, one unable to follow up participant after index admission to hospital. Whereas in the like standard of care only, they have like 3 follow-up indeed, like 3 withdraw consent to further follow-up, and 0 unable to follow up with the particular after index to admission. So it is 3, and in the 2 and 1 is inside. So what their differential dropout between the study group? So it is like only 3 in the group and 2 in each side. So where the potential source of bias identified? So if you go to page number, let me check. So page number 3, limitation of trial. Then like it has written like the open trial have the potential for bias. So the by design, however, the primary input endpoint was assessed by independent clinician endpoint committee who were blinded to group allocation. But the trial intervention did not affect the overall rate of treatment for ACS. So the answer is yes for this one. So which statistical test were used? So if you goes to page number 3 and statistical analysis, so it is basically the descriptive data, and it is in the number, so converting the percentage, mean of standard deviation, and median of interquartile range. So they have done like primary outcome and secondary outcome expressed in a different form. And finally, all the data they analyze in the SAS software version 9.0 as a system of window. So the answer is S. So where the p-value reported, so if you go to page number 7, table 3 and figure 3. So table 3, so they have divided in the primary and secondary outcome and express the p-value in this section. So like for primary outcome, if all cause of death are non-fatal, so it is a 0.79. So p-value is bit higher than 0.05. So we'll discuss later is this significant or non-significant, and they have expressed a p-value for each and every like primary and secondary outcome. And this is the figure 3. So for a plot, so Suraj already explained a bit about this plot. So for me, like basically this the no line of no effect. So each and every like section, like for age, it has crossed the line. So it will like say it is non-significant. So if you see each and every point, then each and every point they have crossed the line of no and significant. So the research that they have done, like they have included everything, but the finding, it say it is like a non-significant because it has crossed every line. And so it is a p-value. So we considered each and every like questions in 7. So where the effect of intervention reported comprehensively, so the answer will be yes. So
That was excellent. Very, very good attention to detail there. I like it.
thank you, Sarah. So I'll go to next question. Is it what the precision of estimate of the intervention or treatment effect reported? So to say yes, no, or can tell, we have to consider where the confidence interval reported. So if you go to page number 7, table 3, then we have this table. So it's a primary, secondary outcome. So they have included like a confidence interval. So it is between bracket 0.65 to 1.4 in each and every one. So they have calculated the confidence interval. So the answer will be yes. So next question is, do the benefit of the experimental intervention outweigh the harm and cost? So the answer to say yes, no, or can tell, we have to consider the following questions. So first is what was the size of intervention or treatment effect? So basically, I could not actually find the effect size, but it is done with like 0.5, 0.1. So they have like a small, medium, and the larger size effect, but they haven't mentioned in this paper. So I only find like effect size, but they haven't mentioned clearly. And
Yeah, the wording is a bit strange. I think they just want to know, well,
yeah,
did something really big, were they able to show clearly what they found?
yeah.
Well worded.
So where the harm or unintended effect reported for each study group, basically they haven't shown like harm or unintended effect to each group. But if you see in the page number 3, intervention, so they have mentioned like 4 related adverse event. So 1, readmission with the possibility related to non-cardiac condition, and 3 non-serious adverse event related to intravenous cannula. So they haven't like divided into each group, whether it is in the CT scan coronary angiogram with the standard care or only with the standard care. So they haven't clearly mentioned. about this adverse effect. And was cost effectiveness analysis undertaken? Like cost effectiveness analysis allows a comparison to made between different intervention used in the care of the same condition. So if you like in the paper, it is not included like cost comparison, but if you go to page number 2, so it says if we include like CT coronary angiogram, it will increase the cost than the standard of care only, but it has not compared in the detail, or it hasn't given any like cost percentage or anything. So for this, so I cannot tell exactly, because the effect size, there is some wording, but it has not given detail. Harm, so it has given, but it has not divided into each study group. And cost effective, it has only said it will increase the cost if we include like CT coronary angiogram, then, but it hasn't like specifically dealt. So I cannot tell in this one.
No, I think that's reasonable.
Okay, so this is the end of section C. So in the section D, so section D will deal with the result held locally. So can the result be applied to your local population or in your context, or would the experimental intervention provide greater value to people in your care than any of the existing interventions? So if you go to question 10, can the result be applied to your local population in your context? To say yes, no, or can tell, we have to consider the following questions. So first is are the study participants similar to the people in your care? So basically it is done in the 27 hospital across the UK. So our population will be in the UK in the Doncaster and Bachelor Hospital. So this is the table, like the baseline participant characteristics. If we see like age wise, like sex wise, any like medical history, presenting complaint, like cardiovascular and medical history wise. So they have, if we check, because it is like a mirror image, like the Sarah already told about like CT coronary angiography and standard of care only. It says it is a randomized, but if we see the both part, it is like similar, and it is similar to in the UK, like in the Doncaster as well. So the answer will be yes for this one. And next will be, would any difference between your population and the study participant alter the outcome reported in the study? So it is done in the UK, so there is no any difference. So next will be, are the outcome important to your population? So basically in the outcome section, so it has already written like primary, secondary outcome. So it is important to see the outcome to our population. Next is are there any outcome you would have to wanted information on that have not been studied or reported? So I think they have studied like all the primary, secondary outcome. So it included all the cause of death, non-fatal myocardial infarction. Also, they have included other death from the non-myocardial infarctions, like any other coronary artery disease, cardiovascular death. So last is are there any limitation of the study that would affect your decision? So if you go to the limitation section of the trial, so the trial, it says like did not affect the overall rate of treatment for ACS. And during the trial, we had like comparison by accepting the larger estimate and relative effective size. And they have explained different like reason why they have like a lower number of the patient in originally. Maybe due to like standard of care include like troponin and the ECG, which is a better diagnostic accuracy for like ACS. And they have included it is in the grace intermediate one. So study is in the intermediate, so they have like a heart problem going on. So so there is some limitation for the study. So can the result be applied to your local or population in the context? So answer is yes. And last question is, would be the experimental intervention provide a greater value to people in your care than any existing intervention? To say yes, no, or can tell. So we have to consider what are the resources are needed to introduce this intervention, taking into account time, finance, and skill development or training needed. So basically, in the study, it has included CT coronary angiogram. So in the standard of care, basically we do like troponin, ECGs, and according to that, we will like determine. So if the patient has like chest pain, like ECG changes with the ST elevation, then we basically refer to the Northern General Hospital from Doncaster. And if like the patient has like non-ST elevated in the ECG, raised troponin, then he will go to the cardiac care unit in like in hospital, Doncaster Hospital. But if the like troponin is less than 2, or repeated troponin after 3 hours is less than 50%, and if there is no any chest pain, then patient can be safely discharged to home with cardiology follow-up in further. So so basically this include like in it is in the A&E department. So if we send like coronary angiogram from the emergency department, like it will take time. And regarding like financial issue, the researchers have not explained about the financial issues, but I think in the NHS system, it is every investigation is free of cost, so they haven't explained regarding the finance issue. And regarding like skill development or training needed, so it is related with the like CT angiogram. And if we found like any blockage in the coronary artery, then they will do like angioplasty, and basically we referred it to the Sheffield Northern General Hospital. So next question is, are you able to disinvest resources in one or more existing intervention in order to able to reinvest in the new intervention? So basically they have included the CT angiogram, but in the final conclusion they have added like early CT angiogram in acute coronary syndrome, it is not useful. So for my setting, I will say it is I'll say no to this question. And final part is like the summary of appraisal. So basically we record like important points, and we will like what is your conclusion to this paper. So basically if you go to page number 10 conclusion section, it is like clearly written like early CT coronary angiography in the intermediate risk patient presenting in the to the emergency department with suspected acute coronary syndrome, or those with a provisional diagnosis of acute coronary syndrome, had no effect on the overall treatment and prevention of the disease or 1 year outcome, and was associated with the increase in the length of hospital stay. This finding don't support the routine use of early CT coronary angiography in the intermediate risk patient presenting to the emergency department with the acute chest pain. So the conclusion of this paper, so when I'm reading this paper, so the checklist wise, the most of the answer is yes, but the result like the p value is like more than 0.05, And the researchers also recommend not to use early CT coronary angiogram for the acute coronary syndrome with the chest pain patient. And regarding like hospital resources, like in the Doncaster and Basildon Hospital, we don't have like angioplasty facility here. So if we need, we refer to Northern General Hospital. So like I could not like recommend it to do like from the like paper side, it has like more than 0.05 p values, that is not significant. And resources also recommend not to use early CT angiogram. And also like the hospital facility wise, we don't have a much resources. But talking to regarding in the context of Nepal, where I work in the Chittagong Medical College in the emergency department, like we have like angioplasty facility in the side of emergency department. In there, if we find like any patient requiring angioplasty angiography, then we directly send patient from emergency department to the angioplasty area and angioplasty room. So for the final like decision wise, like in the paper, it is already like mentioned, it is not to use CT angiogram early for like any patient coming with acute coronary syndrome with the chest pain. And also like facility wise in like Doncaster and Basildon Hospital, we don't have like any angioplasty facility if there is some obstruction in coronary artery to open that artery. So the checklist wise, the researchers have done a good job. They have included everything, but the final like decision whether to use this early CT angiogram in our practice, so the answer will be no. So thank you. That's my slide. If any comment.
Well, I'm very impressed. Thank you both very much. That was a really detailed look at that.
Thank you, Shara.
At one point, I thought you might have had sight of my notes because there's a load of stuff I didn't have. Thank you.
So if we don't have any like comment, then we can go to the third section.
Could I ask for a
Sundar.
short interval?
Sundar, you are cruel. You are very, very tough guy. Could we a little bit break?
Could we take 10 minutes?
Yeah, 10 minutes.
You got better control of your bladder than I have, Sundar.
Oh God.
So we'll have a 10-minute break. So it's 10:51. So we'll start from 11.
Great.
Okay, thanks, Sundar.
Yeah.
See you. See you back.
See you there.